our foster family, we have 10 pets. They are 3 Westies, Saffron, Belle and Beau, 5 tortoises, Herbie and Bernadette, Amy and Sheldon and Penny, and we have the 2 rabbits who are Poppy and Daisy. And the fact that there is several dogs I find really helps, because we've got several children and everybody can have a cuddle at the same time and everybody can get that attention really. The children that we've had and young people that we've had have often spent more time with the dogs initially, because you can have a chat if you want to chat, you don't get quizzed, you don't get asked anything, and they're just lovely company. So this is what we call the den, and it's our semi-independent room, but this goes down really well. It's got its own entrance, it's got its own set of rules. It is somewhere to practice being independent but safely. We're all in the house, they've got access to the house all the time. I've got a key for the den as well, so it's still one home, but this is a separate area for privacy. We've got rooms in the house for younger, under 16-year-olds. This is probably my favourite and most important thing, and it's our welcome book. So we don't really discuss this book, it's just left on the child's bed and in their own time they just go through it. But what is so important to me, because it introduces our family, there's photographs of everybody that's in our house and a little bit about them as well, what the things they like, how old they are. And I think that it's, in the early days, it can be so daunting, and it's like, who am I with? And it's actually really nice to have a little bit of an explanation, and they also can create talking points. Because food and meals are such a high anxiety area for nearly all of the children that we've had, I like them to know what's coming, and I like them to be able to plan and not worry about their evening meal. So we have a Monday to Friday system, and on Sunday I'll plan out what we're going to have, and they simply just tick their name if they want it. And I have found that since we've introduced this system, I'm not getting asked at breakfast what's for tea, because children were obviously concerned, they were asking the question, and it's there, they open it up, and it's really lovely because spaghetti bolognese always goes down really well, and on Sunday you can hear the little whispers, I can't wait till Wednesday. Before a new foster child comes to join our family, it is an anxious
Okay, we're live. I would like to welcome you all to this meeting of the committee, which is being held remotely, with the majority of members joining the meeting from their homes. For the benefit of the broadcast, I will now ask the clerk to the committee, Noel McNanaman, to explain who is attending today and the practical arrangements for the virtual meeting. Noel.
Thank you, Chair, and good morning, everyone. As well as Councillor Girling, the other members present in the meeting today are Martin Wright, the Vice Chair, Kevin Greaves, John Longdon, David Martin, Liz Plant, Kevin Rostons, Stuart Wallace, who should be joining us very shortly, Muriel Wise, Gordon Wheeler, and Yvonne Woodhead. Health Watch Nottingham and Nottinghamshire is represented today at today's committee by Ajanta Biswas, and Martin Gately, the Council's Health Scrutiny Lead, is also in attendance. We're joined today by a number of NHS colleagues to inform our discussions. These are Lucy Dadge, who is with us until about 11:45 this morning, Hazel Buchanan, Stephen Smith, and Catherine Pope. Dr. Mary Anton is able to join us for a short time this morning, but is heavily involved with the ramping up of COVID measures this week, so cannot stay for the duration of the meeting. And unfortunately, and for the same reason, two senior clinicians currently based at Linden Lodge, Claire Donnellan and Louise Elphick, can no longer join us today. The meeting is being held in line with the requirements of the Coronavirus Act 2020. Please do bear with us if we experience any technical issues. If we lose any members from the call temporarily, then officers will seek to assist in getting them reconnected as soon as possible, hopefully without the need to halt proceedings. Officers will inform the meeting if they are unable to rectify the problem and if we need the meeting to be paused or adjourned temporarily. During discussions, and if members are referring to your agenda pack, please refer to the numbers at the bottom when making points. So we're ready to go, Chair. Thank you.
Thank you very much, Noel. Item 1 then, apologies for absence. Noel, are there any apologies?
Yes, back to me again. We have apologies from Councillor Richard Butler, who's on other council business, and Councillor Longdon is substituting for him today. And also Councillor Doddy has work commitments, and Councillor Gordon Wheeler is substituting for him today. Thank you.
Thanks, Noel. Item 2 then, do any declaration of interest, do any members or officers present have any disclosable pecuniary interest to declare? And do any members or officers present have any private interest, pecuniary or non-pecuniary, to declare? I take that as a no. Item 3, a briefing on rehabilitation services in Nottinghamshire. Right, at the outset, I thought it would be useful to remind members of the committee why we are having an additional meeting today and receiving briefings which provides an overview of rehabilitation and neuro rehabilitation services in Nottinghamshire. Back in October, the committee heard about the consultation response on the NHS National Rehabilitation Centre at Stanford Hall. We made a recommendation that there should be an overlapping transition period which would allow the Linden Lodge Rehabilitation Facility to remain open for either 6 or 12 months as it wound down and Stanford Hall becomes operational. Subsequently to this, at our 10th of November meeting, members will recall hearing about the plans to shift services at the Chatsworth Rehabilitation Ward to a community-only model with an indication that those requiring level 2B inpatient care would be able to access this service at Linden Lodge, which we had already heard was not fit for purpose and earmarked for closure. Since members were not happy with the lack of joined up thinking regarding Linden Lodge and the transition of Chatsworth Ward to the community-only model, the commissioners offered to provide a comprehensive briefing of rehabilitation services in Nottinghamshire so that we had a better understanding of the issues. I understand we are receiving a presentation and I invite Lucy Dadge and Hazel Buchanan to introduce the item.
Thank you, Keith. So I've got a short presentation and as Noel mentioned, we have got some clinicians joining us. As Noel was reading out around the names, I did have a text from Dr. Lovelock to say she'll be able to join at 11:30 for 20 minutes. So we'll manage that as part of the discussions. So before I start, Lucy, did you want to say anything before I go into the presentation?
No, just to reiterate Councillor Girling's introduction. So this is certainly an introductory conversation with you to help describe our overarching approach to rehabilitation more broadly, so that you can understand the context in which specific changes are being made. So very much like this to be a discussion, really, and we're really grateful to have clinical colleagues supporting us.
Okay, so I will share the presentation. Okay, can you see that all right?
Yes, that's clear, thank you.
Okay, great. So what I'm going to cover is what is rehabilitation. So just an overall general overview of what is rehabilitation, detail on the neurorehabilitation pathway, and then we've got some case studies for you, which will hopefully help to contextualize. As mentioned, I'm going to go through the specialist rehab case studies. They were going to be covered by the therapist. So, but Dr. Antoon is here to help with some of the real clinical discussions and the detail. So, what is rehabilitation? This is definition, WHO definition that describes all rehabilitation. It's a set of interventions designed to optimize functioning and reduce disability in individuals. And the key element is within their own environment. So anyone may access rehabilitation, whether it's following an injury, surgery, disease, illness, or because of loss of functioning as we decline with age. So the key elements are, though, it's about getting people as independent as possible in everyday activities. So how do we enable people to get back into education, work, recreational activities, and what we call meaningful life roles? So the rehab and interventions can be provided in any setting. So it could be a hospital ward, GP practice, community health centre, local gym, local community centre itself, or in a person's own home, or what we're finding now is also virtually. The rehab intervention helps to address the impact of a range of problems. I think we probably think mostly about the physical problems, but it's sensory problems, cognitive or behavioral problems, communication problems, psychosocial and emotional, medically unexplained symptoms, and mental health conditions. Within commissioning, NHS England have released commissioning guidance, and that outlines 6 phases of rehabilitation. So phase 1 and 2 are the most complex, and up to phase 6, which is the least complex and tends to be in relation to community assets and all activities that are available in the communities. So phase 1 to 3 tends to be what's commissioned and provided within NHS services, and phase 4 to 6 tend to be what's provided by local authority, community services, voluntary sector, and other local services. So and I think what a key point is that it's not a linear process, so you don't automatically go through from phase 1, 2, 3, 4, 5, 6. It's really dependent on the individual needs, and individuals can go in and out of different phases depending on as I said, depending on their needs. There's different professions at each stage. So rehab can include nurse specialists, clinical psychologists, dietitians, rehab medicine consultants, occupational therapists, physiotherapists, speech and language therapists, podiatrists, art therapists, social workers. So there's a huge range of professions, and generally as you're going through the phases, you're involved with more and more disciplines as per the complexity of your illness. And the key element is, as part of that, is it's a really integrated approach. And so it includes elements around housing as well as relevant education. It's all around self-management and individual motivation. So it's how do these all integrate together to provide effective rehab. So it's not about or based on a diagnosis. What's really important is it's around the individual need. So two people with the same diagnosis can follow different pathways and have different needs. And it may be that someone goes through an inpatient with the same diagnosis, one person goes through rehabilitation and the other person doesn't go through rehabilitation. So it is really important to recognize this within any of the rehab services. So it's a holistic and individualized approach, and it's a quite complex interaction between what an individual abilities and needs are, what their aspiration and motivations are, previous health conditions, and how that's impacting on them, and that can be mental and physical health conditions, the environments they live in, and their values and beliefs. The interaction between an individual's mental and physical health is key, and one having a significant impact on the other. And so then that's all taken into consideration as part of an individual's rehab journey. So just give you some examples of other rehab services, and this is just some examples, because as you can see through what I've described, you know, there's a wealth of rehab services. So stroke, we have acute ward and community-based services, and these are patient-centered and goal-led services, and they're set on admission. So that's not on admission to rehab, but on admission to the hospital. It includes a multidisciplinary team, and stroke is probably around phase 2 to 3 in that diagram that I showed you, predominantly phase 3. And it includes specialists such as speech and language therapy, psychologists, occupational therapy, physio, etc. And it fits with early supported discharge as well, and people having rehab in their own home. Cardiac rehab tends to be a 10 to 12-week program of structured exercise sessions, and it helps to build strength and confidence. And this can be provided in an NHS setting or non-NHS setting, and it can be physio-led, or it could be an exercise instructor who's being specifically trained in this area. Pulmonary rehab is slightly more complex than the cardiac rehab, but again, exercise and education programs, but it's really about the person being able to manage their condition, and how do we support them in managing exacerbations and the anxiety that brings. These tend to be 6 to 8 week long sessions, and can be in community halls, hospitals, or leisure centres. And we offer that, or that's provided across the county. And then just to give you context in relation to a different specialty area, in relation to cancer and oncology, it's quite different than the neuro rehab, but it's vitally important. And this is particularly different because it's cancer is obviously one of the few areas where the treatment is actually what's making people functionally worse rather than better. So this does start again right from diagnosis in what is often termed as prehabilitation and continues throughout the individual's journey, both whilst they're having cancer treatment and after cancer treatment, and indeed including in palliative care. And so it's provided in an inpatient setting, outpatient setting, and community setting. And where this one differs potentially than some of the others is that there is a really strong dietetics focus, where that's a slightly different slant than some of the other rehab services, but it includes the same specialties around occupational therapy, physiotherapy, speech and language therapy, and a lot of this would depend also on the location of the cancer, the type of the cancer, and the stage of the cancer. But the key is it is also supported by a multidisciplinary team approach. So some examples are cancer and rehab exercise program called CARE, and that's actually provided by Notts County Football Club, but it's for patients receiving cancer treatment or post-treatment, and is really focused on gym and sport-based programs. Cancer therapy services, both inpatient and outpatient, and that's one-to-one consultations, and for MSK problems, including pain, stiffness, weakness, fatigue, deconditioning, poor well-being. And we've got things like Spring Into Action program, which is 12-week exercise and education program, and that's physio and OT led. Head and neck post-treatment and rehab clinic. And so that's obviously focused on a specific cancer, and there's other programs like that. And that is a neuro rehab, or there's neuro rehab needs, but it's very much targeted in relation to the cancer. And then Move Against Cancer is an 8-week online virtual program. And again, that can be for those with cancer or those after cancer. And there are quite a few programs that are specifically for the end of treatment. So there's a whole range of programs. Those are organized differently than what we think about in relation to neuro rehab. So for neuro rehab, we talked about this in relation to the NHS rehab centre. Tends to be described in relation to 3 different levels. Level 1 being the most complex, and that equates to level 1 in the different phases of rehabilitation, to level 3, which is non-specialist rehab services. So when we look at what we've got access to in Nottinghamshire, so the level 1 services tend to be commissioned by NHS England, because they're very specialist services, so provided on a wider region basis, and our services through Leicester, and that's for the East Midlands Trauma Network. Level 2A, level 2 tends to be split into 2A and 2B. There are discussions as to whether that's a real split or whether actually it should be described as level 2 only. And we've got, as you know, the Linden Lodge, and then there's access to the Lincoln service and the Leicester services as well. So it tends to be level 1, and if we're trying to describe the complexity of the patients, level 1, 2A and 2B tend to be patients through major trauma centres And again, that was the focus through the NHS rehab centre. But locally, Kingsmill Hospital have access to Linden Lodge, and so as an example, with Sherwood Forest Hospitals or Kingsmill Hospitals has referred 5 patients over approximately the past 18 months to 2 years. So that just gives you the context around around the fact that most patients come through the major trauma centre. And then we've got a number of services that are not inpatient services. So those are obviously all the most complex inpatient services, but you can provide some level 2 services actually as outpatient or not inpatient services. So we have outpatient clinics. We have the proposal around the Chatsworth Community Service. There's Community Neuro Reablement Service, which is for the more complex patients, and community therapy services. So just to give you some case studies, and this to help to demonstrate the complexity of patients and the combination of inpatient and non-inpatient services. So the first case study is traumatic brain injury, a patient who had cranial surgery and had gone through quite a number of services as part of their treatment. They had marked cognitive language and mood issues and lacked insight into the individual lacked insight into their own difficulties, poor balance when walking, assistance needed for all activities of daily living, and needed one-to-one supervision for the patient's own safety. So they were admitted to the inpatient Linden Lodge service and for 2 weeks, and required all therapy disciplines as well as nursing and medical input. So it was really complex patient requiring intensive support. The patient's goals were to be independent with activities of daily living, to walk independently and safely, and to increase insights into the effects of the brain injury on daily life. But this patient was discharged early from the inpatient rehab, earlier than was originally planned. And that was because their recovery was being impacted by the previous mental health issues, including self-harm. The individual wasn't engaging whatsoever with rehabilitation, self-employed individual, and was feeling extremely anxious about the business and what was happening. And so because he wasn't engaging whatsoever in the rehabilitation, a decision was made to discharge the patient with intensive support in his own home. And this could only be done, though, because he had an extremely supportive partner, and because the partner's concerns over the mental health issues that the patient had previously, and how they can get this individual to engage with rehabilitation. So as I mentioned, he received post-discharge follow-up from the specialist community therapy neuro rehab team, which included occupational therapy, speech and language therapy, and physiotherapy over a 4-week period. And then you can see that the goals changed to support the patient's decisions on work and finance issues, to educate the partner on cognitive impairment and strategies to support the patient, and to access their community safely. And then following that, it was transferred to the local traumatic brain injury service for ongoing occupational therapy and case management. The second case, again through Linden Lodge, is a spinal surgery patient. And spinal patients are slightly less complicated than neuro patients because they haven't got necessarily the speech and cognitive difficulties, but they are more complex physically. So this patient had weakness in arms and legs, able to stand but not walk, needs some help to get in and out of bed. And they were discharged home. They were discharged home from the spinal surgical ward, but then supported by the Linden Lodge Community Neurospecialist team on an outpatient basis. Again, this was also able to happen because of a very supportive wife who was able to provide some of the assistance that the patient needed. And then after 6 weeks of rehab, the patient was transferred to the specialist neuro rehab outpatient physiotherapy service. And then I'll hand over to Catherine shortly and just after one more case study, which is a COVID patient with neuro complications. So what they're seeing is secondary to COVID. There are some patients that have neurological illness. This patient had a long hospital stay, 4 months, and then had 6 weeks of inpatient, so 6 week stay in Linden Lodge, and then went home and was followed by the community therapy team, and then by outpatients, rehab therapy outpatients, and that's where they have specialist equipment for those patients that need it. So what I'll do now is hand over to Catherine, who's going to talk more about the community neuro rehab services to give you that context again between the real specialist rehab and the community services.
So hello again. Oh, I've got an echo. Hello again, everyone. What I thought would be helpful is to try and describe the mainstream community therapy service, which we have in South Notts, and until the temporary closure of Chatsworth is also what the option was in Mid Notts, and what we're able to provide whilst Chatsworth is closed with a more dedicated neuro rehabilitation community service. So the two ladies I'm going to talk to you about both have multiple sclerosis. So for those of you who aren't familiar, that's a progressive neurological condition that typically people have periods of relapse and then remission, but over time their condition and therefore ability to function gets steadily worse. So if I tell you about the lady in South Notts first, this was a lady in her early 50s, and she was referred by her GP because of decreased mobility and being unable to get out of a chair. And this was leading to her having problems with her continence and pressure areas. So the physiotherapist visited the same day. Her husband was providing all her care needs, and she'd previously been able to walk with a wheeled frame, to use the toilet independently, and got upstairs using a stair lift to be able to go to bed. So that first day, the physiotherapist was able to arrange for all the necessarily emergency equipment that they needed to make the situation safe. So they provided a stand aid so that she could stand, and that enabled her to be dressed and to transfer to and from a commode. And they got her a profile bed that could be kept downstairs because her husband at that time was unable to transfer her from the stair lift to something to then get her into the bed upstairs. And she had to, they got a commode because she was unable to use the downstairs bathroom. So that equipment all came the first day. So that meant they were able to avoid admitting her to hospital. The community therapy team then followed that up a week later, and she had weekly physiotherapy, which involved working on her transfers, her ability to sit and stand, and progressing her back to walking with her wheeled frame again. They also referred her to social services OT, who were able to adapt her downstairs toilet and shower so that downstairs living became much more private and dignified for her. Now, normally in that team, we provide therapy for up to 6 weeks. For this lady, it was extended to 8 weeks. But at the point of discharge, she although she was no longer able to go upstairs to bed, but they had agreed as a husband and wife that it was safer for her to stay downstairs. Now, with a more dedicated neuro team, there would have been the ability to have more intensive treatment, so more than once a week, lasting up to 12 weeks. And we would have been able to involve more disciplines, so maybe involving some psychologists to support them to come to terms with the progressive nature of the disease and to plan for the changes that were needed. So if we compare that to a lady we've seen recently in Mid-Knots, this lady was slightly younger. She was in her late 30s. She also had progressive MS, and she also has a daughter who's 15 months old, and her husband had recently been made redundant. And she was referred because of repeated falls, problems with continence, pain, and also problems with her speech and swallowing. So she wanted to be able to return to be able to get out of the house and to driving again. So for this lady, we were able to involve a nurse, physiotherapist, OT, speech and language therapist, and psychology. They also provided the necessary equipment she needed immediately to make the situation safe, and the treatment worked on improving her balance, muscle strength and mobility. And they were also able to signpost her for support with financial advice and to provide some emergency childcare till the situation was resolved. There were also assessments around her mental health, her mood, cognition and fatigue. Speech and language therapy worked on her swallowing and speech, and OT worked on functional tasks including washing and dressing, and also her ability to manage childcare herself. So they were able therefore to provide interventions from a wider team for a longer period of time. Both these patients had good outcomes. Both were able to avoid admission, and you can see certainly for the younger lady, to have admitted her would have probably caused more distress because of the separation from her child for longer. And in both cases, we were able to provide the equipment and the treatment necessary to regain some independence and preserve their dignity in that. Neither of those patients would have met the criteria for a new rehabilitation inpatient service, but they could have ended up being admitted either to an acute hospital bed or into social care due to increasing risks such as falls or pressure areas leading to infections. But having the more dedicated team has enabled a wider multidisciplinary approach and allowed that more complex situation to be managed at home, which is better for that family in the long run. So Hazel, shall I hand back to you?
Yeah, so that is hopefully gives you a greater context around rehabilitation and the difference in the complexity of patients and how rehabilitation is very much structured around individual need. And so what we want to do is open it up to questions. We have got Dr. Anne Toon here, who's a rehab consultant for a little bit longer. So if you've got specific questions that would benefit from that clinical input, if we could prioritize those, that would be beneficial.
Okay, thank you very much. I'm going to open it up then. I know, Councillor Martin, you put your hand up first, but I'm also aware that Muriel has to leave us first. So I'm going to put Muriel first, if you don't mind. You're not got to leave, Muriel. Okay, well, Councillor Martin then, please.
Yeah, thank you, Chair. Thank you for the detailed report. I suppose what we're talking about really is a changing situation where the services provided at Chatsworth and at Linden Lodge are going to be evolved more into an outpatient basis, because that allows you to have a greater budget to deal with the issues. I suppose from our point of view, we just have to be sure that that's the right path that you're taking, because when Stamford Hall comes online, the more serious neuro will be dealt with at Stamford Hall. Am I reading that correct, Hazel?
Well, so the key element is we need a combination of rehab services across from inpatient through to community, and it's how best do we structure those to meet patient needs. So, and then what we look at in relation to the NHS Rehab Centre is what do we do between now and the rehab centre opening to really develop those further. So I don't think it's not a case that something's stopping or we're trying to move funding more into the community. It's how do we have that overall that overall pathway of care that does cover the inpatient as well as the outpatient. And it's this element around it's really important that the rehab aligns with the individual's environment and supports them to get back into their own home or their own living environment.
Are you happy with that, Councillor Martin?
Well, yeah, so what you're saying really is that you're evolving the way in which you manage the patients. Is that what you're saying?
Yeah, so yeah, I mean, overall, Chatsworth is an opportunity and or what we're proposing is a real improvement to what's currently in place, and it's how does that fit with the overall range of services that we're able to provide, which is based on need. So that alongside the inpatient services.
Yeah, so the overall strategy you're evolving, because obviously once we lose Chatsworth as an inpatient and Linden as an inpatient area, then people have got to travel a long way, and that's our biggest concern. So that's what we're trying to find out. So what you're saying is by reshaping your budget, you're able to deal with people in a different way, closer to their homes. Yeah, so we're not losing Linden Lodge, and I think that's really key, is that we're that service is obviously remaining, and then the Chatsworth beds weren't rehab beds, so that is fundamentally different to Linden Lodge. And so it's it's more around how do we provide a service against the need.
Right, can I just jump in here, because that was something that's just been thrown in the pot there, which has surprised me, and I can see a lot of councillors' head nodding. So you're telling me now that we're not going to lose Linden Lodge?
Oh, well, you mean the physical building of Linden Lodge is, so I guess Linden Lodge is, the service is transferring to the rehab centre.
Right, okay, so right.
So as a rehab centre, we all
So it's not losing a service, though.
No, this is the whole idea of this, though, Hazel, really, is that you said this is what you wanted to do in the first place, i.e. You get rid of the facilities of the Linden Lodge, i.e. that physical building, because everything's moving to Chatsworth, to Stamford, Stamford Hall. And that's where our concern was over the transitional period. So I don't think, and I'll look for anybody to correct me on from the committee here, the overall strategy of what you want to try and achieve, I don't think we're against. What we're concerned about is the transition from where you are now to where you want to be. And that's the whole idea of this particular meeting, to reassure the committee that you've got it pegged out in a way that we don't feel that it's putting any of our constituents at risk. And I think I'm again nods from the councillors on that. I think that's generally the reason for this meeting. So when you said we're not losing Linden Lodge, that's why everybody's ears pricked up, because there's no point for this meeting if we're not losing Linden Lodge. But now you're saying we are losing Linden Lodge, just not the services in the way they're delivered. Is that right?
You're not.
Yeah, I think you're going to reduce the inpatient service at Linden Lodge, and you're going to reduce the inpatient service at Chatsworth and transfer those that really require it to Stamford, and those that don't require it, you're going to deal with on a more outpatient basis.
Sorry, Hazel, can I interject just for a moment?
Yeah.
So in answer to your question, Councillor Girling, as you know, we did what's known as an opportunity consultation on the benefits of developing a service standard at Stamford Hall. So you absolutely, for the avoidance of doubt, in due course, Linden Lodge will close, and those patients that are appropriate through the assessment processes will be treated at Stamford Hall. So I suppose the only thing I would say slightly different, it isn't we wouldn't necessarily have chosen to do so, but we had the opportunity to benefit from the investment at Stamford Hall, and we feel that is an opportunity that we should take. So I think what we're trying to do today, particularly by bringing some case studies to life, is just to give you a bit more assurance about the services that wrap around Stamford Hall. But yes, Linden Lodge will close, and we wouldn't want to mislead you. And as we described to you, so today wasn't so much about that mobilisation programme, because I think, as we discussed at the last meeting, when that happens, and Dr. Antoon, if she's still here, would hopefully will support this. We will manage patients on a patient-by-patient basis. There will be patients that will already be in Linden Lodge when Stamford Hall opens, and there will be new patients that will require Stamford Hall, and we'll manage that transition on a patient-by-patient basis. But I think what colleagues are trying to do is to describe that there is a whole community wraparound to whatever inpatient care is provided.
Would Dr. Aunton like to come in on that?
I've just realized that I was trying to speak, and actually I had my microphone off. Okay. So I'm glad you mentioned that. So I think, as you know, the patients say from Chatsworth, now they've been coming through us. So there is different two main pathways, I think, which Hazel said, either major trauma or neurosciences. So they come to us. There's other patients that, because I personally have been involved, those patients who are not within that pathway that I've get to see. So just to assure you, as a clinician, the patient's needs are being met. And that is, as we, is been in the presentation, it depends on the patient's needs. So when I go and see a patient, I have to make sure, that this patient, because, as Hazel said in her presentation, every patient needs, they can have the same diagnosis, but their needs are very different. So some patients, and as you've heard in the case studies, and actually, the first one is actually my patient, they do much better in the community, and their rehab and the outcome is so much better. So just to emphasize that point, which I think is really been illustrated very well from the presentation. The other thing to say, when you talk about transition, the way I see it, so there should not be a gap in between, so say, for example, and that's my understanding, and I think that is, what should happen is, like, say we are here in Linden Lodge, we're going to move in 2 weeks, whatever. We're going to have all the patients, so nobody is going to be left, their needs are not going to be met in the transition. So the same clinical need is going to happen. Now, if the patients, and I understand that there's some patients, like, they're going to be moving to Stamford Hall, and it's a bit further, but there are advantages in Stamford Hall that the patients will gain that may be not possible here. So I think there's definitely advantages. The other thing to say, some of these patients, say if they're from Mansfield, they can't go home anyway, whether they are in Linden Lodge or in Stamford Hall, they are an inpatient. What is the difficulty, of course, is their families who can't maybe visit them is just a bit further up. But I talked to a number of patients, and and just for my own interest, for the inpatient, say, well, actually, say, for example, I see some patients and say, we need to send them to Sheffield. We still get spinal patients in. And if I convince that this patient will be better in Sheffield, I really tell them, and I just say, well, actually, this is what is needed. So majority of the patients and the family say, well, actually, I want what is best for myself, for my patient. So sometimes the distance becomes secondary on the fact that there is benefit from where you're going. And that is really, really important. And I think as clinicians, that is what we tend to do. So like I said, with the transition, I do not think that this should actually, and in between, that the patient's needs are not being met. I think that will be really sad. I don't think that should happen, and I don't think it should be happening anyway. So, just to assure, because I think it will be the same. I'm going to see patients and I'm going to just exactly do the same advice. This patient, like, better in the community, better in Linden Lodge or NRC at the point, or wherever it is. So it will always be patient need that is being the focus, is the main thing. So okay. I hope, I've answered,
Yeah, sure. Can I just sort of clarify something then?
Yeah.
From something that you said, and I think it'll be good for members to understand this, is I understand that it makes it more difficult for the patient's parents or family to actually visit them. Yeah. But in your professional opinion, you are saying that overall, them going to Stamford Hall is more beneficial because of the advantages of what you've got there.
Yes, this is what I'm saying, and, okay. And to be wise personally, and I said that to a number of people, maybe, I am really waiting for the day when NRC opens. Initially, there's been delays, and I'm really excited that this happens, and, if I can speed the process, I would. So I think it's an opportunity that is really going to be really great. I think it's going to be for rehab, in the center. I'm really, really personally proud that I'm being part of this, and just to sidetrack a little bit, some of my colleagues, from rehab, and I know somebody want to relocate just to be part of this. So it's an amazing opportunity with research and is everything, and it should be, really a good opportunity that we, have to facilitate. There is nothing is going to be like that suits everybody, but I think the benefit definitely outweighs that. And now, as you probably know, what we have, because of COVID, even visits are not as before, but we're doing the MS, the FaceTime. So that is all, have reduced the problems, as in, the patient not able to see. So there are ways to cater for what is missing.
Okay, and just one more question from me, because it's just for reassuring members, really. And are you confident in terms of the system in which has been looked at to transition from where we are now into the model that we want to be, that people are not going to fall through the gaps? Because that's our main concern, that we will, somebody will suffer as a consequence of the changeover.
I mean, like I said, I have been involved, for some time now. And I think, as long as we are involved as clinicians, I can definitely make sure if we feel patients' needs are not being met, we're going to raise our voice. Because I think that is, as clinicians, that is what we do. So, and that sometimes that can happen at the best places. So I can, as long, like I said, we are being involved as clinicians. If that is an issue that I can see, or I'm sure my colleagues will see, it will definitely be raised. The patient needs is number one. And I suppose all of us, that's what we want for ourselves. We want the clinician to make sure that you got the right treatment. And I can assure you this, and, with my team, they're not here, but we can always say, yes, the patient needs is one, if it doesn't happen in the transition, we're going to raise our voice to make sure that that does happen.
Lovely, thank you. Muriel, you've got a question.
Well, 2 or 3,
Okay.
Chair, if that's okay.
Yeah, of course, absolutely.
Just before, just to thank Catherine Hazel for the presentation, which has shown how very complex the whole area of rehab in this field is. But just to continue Keith's question, just to clarify, one of the issues we were looking at was whether Linden Lodge should stay open for longer than you'd initially planned to ensure that that period of transition was safe. And I'm not quite sure that's been clarified about what the timescale for Linden Lodge's close might be. Because I think we were looking for slightly longer than yourselves were. But my questions are, I mean, clearly, particularly the cases that Catherine mentioned, are such a strong argument for rehab in the community being more effective than continuing to be in hospital. I don't think there's any argument about that. It just seems to me from the cases that Catherine mentioned is a lot depended on the partner of the person who needed support. It was very dependent on a high level of coordination between services. It's pretty sophisticated work. So my questions are about, first of all, what kind of budget challenges are being faced, not just now, but perhaps over the last 4 or 5 years, about resourcing this high level of community support? I suppose the question might be, is it more costly for folk to be in rehabilitation at home than in an institution? So there's a budget issue. There's also the coordination with other organisations. I mean, I know quite little about Headway, and I know the challenges they have for funding and so on. I just wondered how that funding is working out for partners, particularly in the voluntary sector, who contribute so much to this. And the third question is about long COVID. I mean, even from the folk I know, one particularly close friend is experiencing not only physical lack of balance after COVID, but a high level of anxiety and memory loss, which is not improving quickly. And so I suppose the other question is financial as well. How confident are you that the resources will be there for long COVID support, which is obviously an additional burden to the work you already have? Thank you.
This one for you, Lucy.
Yeah, I'll have a go. But again, Dr. Anton and Hillary's not on, but if there's any clinicians want to pipe up as well. So in terms of the closure, forgive me, Councillor Wise, if you think we're not answering that question directly. It will be what it is. I think really, and that's not a glib answer, but at some point in 3 or 4 years, we will have an opening date for Linden Lodge, obviously, once construction starts, and that, NUH will be able to say, this building is ready to open on the 1st of April 2025. And we don't, and we've got estimated dates in our programme at the moment, but as Dr. Anton said, the sooner that can happen, the better. So we will then, what Dr. Anton will do with her colleagues in Linden Lodge is review all the continuously then and review all the patients that are in Linden Lodge, and also we will set up the multidisciplinary assessment process for future patients. And the transition, it will just sort of happen, and I say just happen, it won't just happen, it'll be very carefully managed. So they will look at patients who are in Linden Lodge who they conclude clinically there is no benefit to them being moved to Stamford Hall. They complete the rehab journey in Linden Lodge, and then they get whatever community support. There may be, and again I'm speculating, patients that are in Linden Lodge that they say actually this person has such rehab potential, they will benefit from a transfer. And then there will be some patients that are not yet, sadly, afflicted with whatever illness or injury, who I would imagine from the day that the unit is open and the multidisciplinary assessment process is up and running, we'll go straight to Linden Lodge. So we don't want to set a date. We won't set a date because we can't. I think there are, I mean, you know, candidly, there are clinical imperatives of, I think, you know, Dr. Anton has highlighted that they will want to get as many patients as they can who will benefit into Stamford Hall as soon as it opens. And obviously there's a financial element to running two services, but we won't be driven by the finance. We will be driven by the management of those 25 patients that are in Linden Lodge and any new patients that require the service. And when we develop that kind of, when we're closer to the time, we are, as I said last time, very happily come talk to you, because I think the key things, there'll be a date the building is going to be opening, and there'll be a date ahead of that when the multidisciplinary, the MDT that reviews patients will set up, and we will be able to report on and to you, and hopefully we'll be coming to you with a sort of, you know, a retrospective that said, you know, as of this date, all patients have been safely transitioned. So we suggest 6 months, could be 12 months, but I suspect clinically it will be as fast as we can, recognising what you said about patients not getting lost. So that would be that was my first answer.
No, thank you. That's clearer. Yeah.
Is that okay? And
yes,
you know, in a few years ahead, I sincerely hope I am still around. But I'm absolutely, if you put it on your forward plan, I will be delighted to come and talk to you about that, as I'm sure colleagues will. So the broader question, I suppose, about money and have we got enough money for community and specialist rehab? I'm a commissioner, aren't I? So arguably we are responsible for allocating the resource that we get across all of our health areas. I'm sure providers of these services would say there's never enough. And I, you know, I think it would be disingenuous for me to say that everything that we want to do is fully funded. I think, again, not a direct answer, Councillor Wise, but what I think Dr. Anton is saying is that having Stamford Hall on our patch gives a real focus on rehab in Nottinghamshire, and there hasn't been. I mean, it would be, you know, I don't want to be disingenuous, but it's not one of those services. We hear a lot about ED, don't we? We hear a lot about, you know, cancer. We don't hear as much about rehab, and you know, and I think actually having Stamford Hall and this research and innovation will. It kind of brings it to the forefront of all our decisions. So I suspect no, we don't. There isn't enough funding nationally for all the rehab, community and bed-based that everybody wants, but I think this gives us a real opportunity. One of the things that we can't quantify, but we do expect longer term clearly, is to release funding from other areas of public services, so work and pensions and all. So one of the longer term views is that if you can reduce the amount of time people spend not having active rehab in acute hospitals, and you can really focus on intensive rehab and get them back into work, there is a wider financial benefit. That's always been a pretext to the case, but you can't actually prove that yet. But the plan again will be to start to prove that and to shift resources. So, I mean, I don't know whether colleagues, Catherine.
I think Hazel wanted to come in. Sorry, I missed you before, Hazel.
Sorry.
I can answer about the long COVID afterwards if you like, Hazel.
Yeah.
Well, I was actually more around the transition and some conversations that Mary and I have been having. So just quickly then, just to say, so Mary and I have been talking about where are some inefficiencies now and what are the opportunities with the rehab centre. So what can we start to work on now and develop based on us knowing that we're going to have the rehab centre. So that will only support the transition because it's looking at the rehab centre really in the round and in relation to the services that we have, and also the integration and the links between acute, community, and inpatient rehab services. So there is a whole, whilst it's 3-4 years away, there is a lot of work that's happening now in preparation for that, for the opening, and it is providing opportunities around how we can improve rehabilitation.
Brilliant, thank you. I'm going to, before you, Catherine, I'm just going to bring Dr. Anton in because I know she's got to go soon. So do you want to come in first, Doctor?
Yeah, I'm happy to stay a bit longer because I think, I think this is really, my heart into this. So I have delegated my other commitments. So I'm happy to stay as much as needed because I think it's really important to get this opportunity, for, non-clinicians, because like I said, I've been doing this job for, quite some time. So I think Catherine was going to talk about the long COVID. If I just may, just from the clinical side of things, if I could just, and maybe just put other things that I think, Stamford Hall will help. So let me just say with the long COVID, I used to work, sort of like the person who was running the chronic fatigue service for a number of years until it sort of like moved, away. So, and I, in a way, I'm just seeing, the number of patients and even colleagues, doctors who have long COVID and who have not been able to, to return to work. So I think that's such an important thing, to be tailored. And I know this is not necessarily inpatient, but just as in the general rehab, to cater for those patients. The other thing with the MS patients, as Catherine said, there are a number of MS patients that would better, yes, there are some who are in the community, there is no doubt. There's other ones that actually need to be an inpatient because they have so many issues. And the best thing is that they are actually inpatient where you sort things. I've recently, not too long ago, 2 weeks ago, seen a patient in my clinic, MS 44. The number of issues that this patient, I spent 1.5 hours and we did not talk about everything. Seriously, I'm just, telling you, and, and if we don't cater for these patients at the right time, they will end up with more complications that we will not be able to help. So, like I said, rehab wasn't, maybe like the forefront, but it really, you have these long-term patients who are really need so much input that needs to happen before things get too difficult for them that you do very little and then you're spending actually the money in a care package. If I might digress a little bit because, and it's the same for patients who have like mental health problems, things like this, there's a cry for help. And then we see a number of patients self-harm, hanging themselves, ending up with us with, brain injury. And the care that these patients need and the management, you can imagine how complex it is. So sometimes we really need to step back and say, well, actually, I know there is maybe, money is always an issue. We can't have money for everything. But if you don't spend it early on, you're going to spend it so much later on. And I think that is really, really important, to consider that. I don't deal with the finances as the first person, but I see what happens to those patients when they haven't had the care at the time they need it. So just wanted to throw that in, and like I said, I'm going to stay. If I need to go, I'll let you know, but I'm going to stay for at least another half an hour.
Oh, thank you, Doctor. Catherine, do you want to come in now then?
Well, it was just about the long COVID. So just to tell you that we've got a steering group across the whole ICS, so the city and the county, working up a model to provide the multidisciplinary clinics, and we're nearly at the point that have been able to for commissioners to actually commission and then us operationalise it. The bit that's been funded by NHS England is the assessment clinic. So patients will who've not responded to any of the self-care offer will be able to be assessed by a range of disciplines that includes looking at their physical health and their any mental health issues, and then signposted to the appropriate service, whether that's provided by secondary care, community services, or the independent or voluntary sector. So we think there'll be a good pathway in place. Obviously, what we don't know at the moment is what the demand for that will be and what the impact will be on every other patient who also needs a service. So, you know, from a clinical point of view, they'll just be prioritised based on their need, the same as everyone else's. So they won't be jumping the queue, if you like, but there might be more people needing services than we can manage. So it might be an impact on that, which we'll just have to monitor and feed back to NHS England. And I'm sure that's the same for everywhere else in the country as well.
Yeah, we have. Yeah, I mean, I must admit, the post-COVID, when you've had COVID, the mental health issues that it can bring. Actually, a friend of mine, wife had it, and she actually committed suicide. So it is very, very serious impact it's having on people's mental health. Yeah. Okay, I've got. Sorry.
Thank you. Keith, could I just say thank you to Catherine and Mary for those answers. That's very reassuring that there is a steering group already in place. And I thought Mary made the point very strongly that actually a lot of rehab is preventative in its nature. So, you know, it's not just an end in itself, is it? It's actually impacting on future possible negative situations.
Yeah, absolutely. Thank you. I've got Councillor Martin Wright now, please.
Thank you, Chairman. Thank you, Chairman. I'd like to be a little bit more parochial, if I may, and talk about Mid-Notts and Chatsworth Ward. We all know how distressing, disastrous, whatever you want to call it, COVID-19 has proved to be. But of all the bad things that's come out of COVID, it's also presented opportunities. And I feel that the CCG have taken this opportunity to close down Chatsworth in all but a final decision. Even on the presentation we've had today, there was the Neuro Rehab pathway. It indicated that Chatsworth had already gone, even though we understand the decision has not been made. We all remember, those of us who were about at the time, the furore in Mansfield, where staff and patients and families took to the streets when the closure of Chatsworth was first announced. And we asked the CCG to attend at one of our meetings and discussed it with them. They went away, came back, and they made a promise to us. And I've got a press release here dated December the 18th from the then Mansfield and Ashfield Clinical Commissioning Group, saying that patients with neurological rehabilitation needs and brain injuries deserve high quality care to regain their independence. And so we will continue to offer inpatient beds as long as they are needed by patients. That's why we are working with Nottinghamshire Healthcare to develop a flexible community outreach service that can support patients in their own homes. And we've heard about that, and we know that's the way the direction of travel at the moment. But it also goes on to say, but we also need to make sure that we have the right number of neuro rehabilitation beds at Mansfield Community Hospital. And the new arrangements will ensure that we need a bed for neurological or brain injury rehabilitation centres can still be cared for in Chatsworth Ward. Now, I know we've moved on from those days. COVID has forced the closure of Chatsworth on a temporary basis, but it seems to me that the decision is almost being made to close it permanently, and we shall see what happens there in the future. But I'd like to draw the committee's and the representatives' attention to the two examples that have been given to us today about people who were cared for in the community. They both had very supportive partners, stroke husbands and wives, etc. What happens to those people who haven't got such support at home from North Notts? Those people who would benefit from a bed? With Linden Lodge closing, are they going to be transported down to the new NRC to receive care? What will happen to them now that Chatsworth is closed? Thank you, Chairman.
Right, I think Lucy will come in first then, because that's about the actual closure of Chatsworth, and I'll bring in Catherine about the care, and then is your name Mary as your first name or a surname? Because the way it comes up, Doctor, it says on my thing he's got Mary last, Anton Mary.
Oh no, my first name is Mary.
Okay.
Yeah.
Right,
And by the way, please say Mary is absolutely fine.
Right. Okay. So I'll then bring in you last, Mary, to talk about
sure.
your side of it.
Yeah.
Okay, Lucy, if you go first then.
Yes, and can I just introduce, we've got Dr. Hilary Lovelock here, who I suspect counsellors in Mid-Notts will know is a very well established and very well respected GP in Mid-Notts, who will have had patients and understands the Chatsworth unit. So, Kat's right, I understand your perspective and the coincidence, but I have to say categorically the CCG is not taking the opportunity through COVID to close Chatsworth, and I do want you to be, I can only give you that assurance. That's not a reassurance, that is an assurance. Today, in fact, I would have been in an A&E delivery board today. We're under incredible pressure across the whole system. The hospitals, as you know, are full of patients with COVID. We are making decisions not to do other activity. The bottom line is people should not be in hospital at the moment unless they absolutely need to be. And that is the situation that we're in. And so the view is that a hospital ward is not the safest environment for a patient who doesn't need to be there. And also, as you know, we've got workforce pressures. So we're using more of our capacity to manage COVID patients than anything else. And that's the situation we're in. Your quote that you give from 2018, almost certainly I will have been part of that, because I've been through this all the way. And just to be clear, our intention always was, I think we did say that if we reach a point where we feel that beds are not required and patients can be cared for properly in the community, we will come and talk to you about that. And I think that is where we are. Now, Catherine will be able to probably support that view. So I just would want you to feel sure that we aren't taking an opportunity to close Chatsworth on the back of COVID. Absolutely not. But I'm going to probably hand over to Catherine and possibly Hilary as well, who will have a sort of very operational, clinical view of the situation in Mid-Notts as well. So, Catherine.
Thank you. Brilliant.
Yeah, I just want to say that absolutely, if somebody needs a hospital bed because of their health problem, they will always get a hospital bed, whether that's because of a neurological rehabilitation reason or just because they need a hospital bed. Unfortunately, if somebody is at home just and needs care support, then that doesn't mean they necessarily get a hospital bed, because of the pressure on hospital beds, which is obviously worse at the moment because of COVID. But in any winter, we have pressure on hospital beds, so they have to make sure that the people in them need health care. So what would happen to my two ladies is they would go to social care to get a package of carers in to support them, so that again, ideally they could stay at home. But if they couldn't stay at home, then they would have to go into a social care facility, because they wouldn't meet the criteria for Chatsworth or another hospital bed based on their healthcare needs. It's not the case that if we keep Chatsworth open, that means people can go in there because of social care needs. They would still only be able to go in there if they had a healthcare need.
Are you happy with that, Martin?
Well, I don't expect him to be happy with it. It's not ideal, is it? If in an ideal world that wouldn't be the case, but that's healthcare policy, really.
Yeah.
Can I comment?
Yeah, you're on mute, Martin. Let Mary come in first.
So I was gonna, exactly say what Catherine said, because at one point the patient will have to go home. If they finish their rehab, whatever they are, you're not gonna keep them in hospital, whether it's Chatsworth, whatever, just, because their rehab has finished, and we'll have the situation is that they need to go home, but they need support, and that will depend, do they have a family, you know, who can support them. So we are in this situation, you know, all the time. So just emphasizing, you know, the point that Catherine has said, they need a bed, they will have a bed, they don't need a bed. There has to be arrangement done for them to support them in the community. So, and I usually just say, you know, to the patients, there are stages, you know, there is some time of your rehab that you need to be an inpatient. There will be a time in your rehab that you need to be an outpatient. And then we will work that out, how the support, of course, when they're inpatient, they will have the support of the whole team. When it comes to the outpatient, we will look into that, but it doesn't mean that they have to be an inpatient. So I hope that sort of, so the other thing that I wanted just to also mention, you know, about Chatworth, before Chatworth, you know, even when Chatworth was open, we've always had the more complex patient that come to us in Linden Lodge. I don't know sort of the, you know, sort of the why that has happened, but, you know, the head injuries and the complex ones and the one who are wandering and, you know, very, very complex patients have always come to Linden Lodge. So that hasn't changed, you know, so just to, you know, just to add that point. And I guess that's all I was going to just say, you know, in response to what Martin's questions were. So I'm just going to stop here.
Thank you. Do you want to come in, Hilary, before I bring Martin back?
Yes, I mean, I don't know if you know my background. I'm a GP out at Briley Park. Prior to being a GP, I was actually an anaesthetist and worked at Queen's, so worked at intensive care and everything. And now I'm the Mid-Nots representative on the Nottingham and Nottinghamshire CCG governing body. I feel as if I have been through the Chatsworth story endless times, because I remember it at Mansfield. I remember it going out to Ashfield. I then remember it coming back again. And so I feel as if I've been on this whole journey with you. And I've obviously seen how my patients have used it and experienced it. And I can remember from my intensive care days, the patients who had severe brain injuries, those who have Guillain-Barré, and then we've got all those with MS. And to be honest, we now know, we've learnt so much, that if people go into a ward and they don't have intensive physiotherapy, you can actually still even get deconditioned on a ward. Because if you just have small periods of intensive in physiotherapy in the morning, on a ward you sit down much more than you do at home. So there is something about being in your own home environment and having intensive physiotherapy at home that really does make a difference. And you learn to do the things that you actually need to do to give you an independent life. You know, if it's the steps that it's outside your back door that you can't manage, you know how you're going to get to the shop. So it's very focused intensive physiotherapy if you're at home. Now, I know the real issue is that Stamford Hall does seem a way away for my patients, right out at Huthwaite. But to be honest, if I had a severe brain injury, if I had long COVID, if I had Guillain-Barré, if I had multiple sclerosis, which, you know, can be very debilitating, that sort of new rehabilitation that can be done at Stamford Hall, which is going to be all encompassing, it will be very holistic, it's going to be intense, and we're going to have opportunities that we would have never have thought of before, because it's going to be a research centre. It's going to be supported by the military side. You know, when we look at the remarkable things that we've done with the patients that came from Camp Bastion, we can do remarkable things if you put intensive physiotherapy in. And we have so many people with, say, Guillain-Barré syndrome. It's a horrible illness. You're ill for, you know, it may be a year. If they are out of work for that year and they stay out of work and they don't get intensive physiotherapy, they never get back into work again. But if we can do something really different, then hopefully those people get back to normal lives rather than becoming long-term sick, living with an illness for the rest of their life. So I see this as two things. And my patients probably are going to be the furthest from the new centres. But if they can have really intensive physiotherapy in their own home, I think that is the right thing. If they really need it, then Stamford Hall will be the right place. But, you know, we all have to make sure we know it's going to have room so that their relatives can go and stay. It is not that far in the grand scheme of things, because I've had a patient that went all the way to Stoke Mandeville for his rehabilitation. So I feel this is probably the right thing to be doing, although there's that distance thing, and it doesn't quite feel right that it's not in Nottingham, but actually that's where it's going to be. It's certainly that. If I put myself as the patient, I can see that my patients loved Chatsworth, but actually I have to begin to say, was it really doing the right thing for them now that we've moved on in how we did? Because we think of things much more holistically. We think much more about the psychological side. We want all the supporting things around them. So sad as I am not to be able to think that Chatsworth is an option, I think probably this is the right move. I'll stop there and you can ask me questions further, but
I think,
you know,
I think just for clarification, Hilary, we absolutely understand that Stamford Hall is the absolute right thing to be happening. And actually, just for your information, it is in Nottinghamshire, and we're very proud of it.
Yes, it is. It's just in Nottinghamshire.
It is. Well, just is just. So it's not that's not really our concern, and where the travelling for the patients' parents is a bit of a concern, but you know that's part of Nottinghamshire County Council putting a solution in for that in terms of public transport infrastructure. This is more about our concerns about the transition from where we are now to getting it so that we're all in Stamford Hall. And that's why we're having this additional meeting, because of the concerns that the committee showed on that. And the whole idea of this meeting really is to persuade committee members that actually we've got faith in that transition, and we don't need Chatsworth House to be open for an additional 6 or 12 months. So that's the whole purpose of this meeting.
But certainly the other thing was that, you know, we've got to build this strong community rehabilitation, because actually when patients actually come home from Stamford Hall, they will still need the support. And very much, I went to the Senate meeting and they were very much that we needed very strong community rehabilitation to be the step up and the step down from Stamford Hall.
Yeah, totally agree.
Yep. It's building this community base at the moment so that we've got a good platform to start from and land on.
Yeah, I think again, I think the committee understand that, you know, and as was spoken, I think Catherine said, in fact, no, sorry, I think it was Mary that said the fact that when you're at home, your physiotherapy type thing is more intense, because you've got to get up and make yourself a cup of tea. You're not sat in bed, and you're not sat down longer periods as if you were in a hospital having somebody bring you a cup of tea. So we understand that. We absolutely understand that. It's all to do with the transition from where we are now to where you want to be, that nobody falls through the gap. And I think that's what this is all about, reassuring us on that. Okay.
Can I, Keith, sorry to interrupt.
Is that Hazel?
Yeah. Hilary's just got to go in about 6 minutes, and I think what would be really key is because the main element was around the Chatsworth community, what we're calling the Chatsworth Community Service. So not having the Chatsworth ward, but having the Chatsworth Community Service, which would be for patients who don't need the level 2 intensive rehab, and the benefits of that. And I think, and it's just making sure that Hilary is able to comment on that before she goes at 12.
Okay. Do you want to do that then, Hilary?
So, Hilary, because the proposal is around the having community rehab provided by Notts Healthcare, which is the multidisciplinary team. And there's obviously key benefits to having that community rehab focus, which Catherine, before you joined, Catherine was able to give some case studies around MS patients that would benefit from.
And I read those case studies last night, and I absolutely do believe it is important that we have this strong community base, and we have got a much stronger community base than we previously had, you know, which has been developed over the last few years, where we do much more rehab in the community. So I do think we are in a strong position for doing this now.
Okay, thank you. Are you okay, Martin, or you've got anything to come back on?
I'd just like to thank everybody for their answers, and particularly Hillary's answers, because I know her enthusiasm really carries people along, and I've got to say I'm very impressed with that. Just to finish my little moan, just to pick up on what Lucy said, I don't think that when the Chatsworth saga started and came to health scrutiny the first time, and it resulted in staying open with less number of beds, I don't think it was ever made clear to health scrutiny, and other people will correct me if I'm wrong, that they were ever intended to close it in the future. Now that things have changed, COVID's come along, the wards had to close. Everyone's gone into the community. It seems to be working pretty well, but I've still got my concerns about the people who have their physiotherapy at home, but they've got no support. The rest, when the physiotherapist walks out the door, they're left alone. If you've got a partner, that's great. You could say it's a social care issue. Well, we could argue that as well. But I'm uplifted by what Hillary said, and Mary, very enthusiastic. So we'll have to see where Chatsworth ends up. But I'm not really convinced that a wholly community-based service is the way forward. But if the medical people are, and the medical people reassure this committee that's the right way forward, then that's the way it would seem to have to go. Thanks very much, and thanks for your answers. Thank you very much.
Thanks,
indeed.
Martin. I'm going to bring Mary in next.
Do you know, I got distracted by my phone, so I forgot what I was going to say.
Okay, don't worry,
really
Mary.
sorry.
I think we're being persuaded that the community base.
Yeah, but I think I was just going to say, you know, the community, you know, so just with the transition, with everything, we really need, so that, as I was saying earlier, there's inpatient, the outpatient. What we need, if there is anything, to develop the outpatient facilities, so at least we know some patients have what they need, because they don't need to be an inpatient. Sorry, I know I've repeated that, but I think it's just stressing that, and then just saying the situation will be the same for some patients, because they will not get particularly back to full recovery, and they won't have family to support them. But at the same time, you know, being an inpatient is not going to be the solution. I know I've had some patients, and along the line, just to give you an example, like, you know, we get them, you know, say after an acute injury, and I have some patients, it's just the psychology that they think if they're in Linden Lodge, this is their final, like, this is it, you know. So I say, well, actually, no, that's just a step, you know, and that's how I get some patients to engage. I say, well, actually, you're here only for a short time. You're not going to be here forever. But sometimes, unless you say that to patients, because that's what they think, and they get really, really very sad, you know. It's like, I'm like, there's no hope for me. I'm in Linden Lodge. I'm going to stay in Linden Lodge. So it's just a different psychology, different needs, you know, all that.
Lovely. Thank you, Mary. All right, I've got John Longman, who's been very patient because he's had his hand up a long, long time. Go on then, John.
Thank you, Chair. A couple of questions, really. One of the things that's not been clarified, in my opinion, has not come across. I think it's been asked, but not been clarified. When the move from Chatsworth and Linden to Stamford, I get the impression is this going to be a phased move and not what seems to be coming across a rush to save money. That's a question. I also got another question. Somebody say in my situation, I live alone. If I for some reason will fall ill and have to have some rehab, my nearest siblings are several miles away. I have good neighbours and good friends, but it's it'd be a situation that many of us, like myself, could be in a strange situation. How would that be dealt with? I also agree with Hilary. When you've been very ill, poorly, or you have some rehab, to get yourself strong again, get back to work is a target. That's my experience when I went to crack my chest several years ago. But people think sometimes I've got asthma. I've not. It's just when they crack my chest off when it's been took away. Well, quarter of it and some ribs. But that's another story. Also, I'd like to congratulate them. I've got a case in my town where it was in Neuro for the best part of a year. And he's come out and he's got good support from his family. I know his parents, lived on the same street, good lady, good friend. And recently we raised at a local workman from £700 to assist in adapting his house for him. But I think eventually he will get back full back to work. So there's observations and 2 questions there. I'd like 2 questions answered. Thank you, Chair.
Who's going to take those on then, please? Somebody's typing. Whoever's typing, can you put yourself on mute?
That's right.
It's fine. You can type away, but can you just have yourself on mute, please? Who's going to answer that? Who's going to answer John's question then, please?
So I'll start, and then I'll pull Catherine in to talk more about patients who are living on their own. But I think Chatsworth, John, you mentioned the move from Chatsworth and Linden to Stanford Hall.
I get the break might be a rush.
Yeah, no, it's Linden Lodge that's transferring. Chatsworth is the Chatsworth ward at the moment isn't fully neuro rehab. So and that's where we'll have, or we're proposing that we'll have a community service. But it's a whole different level of rehab, which you're trying to explain through the case studies. So it's understanding the individual need. But it will be a phased approach in that I think we're trying to describe earlier, where so there will be some patients that Linden Lodge will decide maybe need to transfer to the rehab centre, but actually they're probably better to be discharged home. So they're nearly ready to be discharged home. So they wouldn't transfer to the rehab centre and then be transferred home. They'd probably stay at Linden Lodge till they're ready to go home for a period of time. And then there's other patients that, you know, if we have to wait a week, let's say, for them to go to the rehab centre, they're in an acute ward and they'd absolutely benefit from the rehab centre, then, you know, and let's not transfer them to Linden Lodge and then transfer them to the rehab centre because you've got 2 transfers. So it will wholly be based on individuals and also around patient safety. So how do we manage this in a safe environment? There's absolutely nothing to do with the funding element. It's around the patient safety and how do we move patients at the right time into the rehab centre, and that will depend on their needs, where they are in their care pathway, whether in the acute ward at the moment or whether they're in Linden Lodge. So and we will have a more detailed plan closer to the time, and think that we'll come back and absolutely come back and go through that, but it will be on an individual patient level. How do we transition them to the rehab centre? And then living on the rehab centre proposal includes, you know, things like clinical case managers, and this is following people through to discharge. And it is around all the holistic needs. So how do we look at the individual in the entirety and what their needs are? And this is around the integration of services. And so how do we make sure they've got everything in place? And that would take into consideration whether someone's living on their own or not. And then Catherine can just comment on if someone's, they're not specialist rehab, but they're having rehab in the community, which I'm sure happens now, Catherine, doesn't it, with therapy services, is how do the services support people, whether they're on their own or not on their own? And that's about looking at the person in their entirety. What are all the assets around that individual, and how do we support that individual? Sorry, Catherine, add more detail.
So, so we have our own support workers. So these are people who aren't registered as a healthcare professional, but they have been trained to be support workers. And also we work really closely with social care. So what we would do, as Hazel said, you assess someone and you're looking at what support they have or don't have. And first of all, are they safe? Are they safe where they are? And if you determine that they're not safe, then it's looking at, so what is needed to make them safe. Now that might be having people come in to do more regular visits, either our healthcare support workers or social care support workers, and they can come in multiple times a day. So they might come in and help you get from out of bed in the morning, get washed and dressed, and then go back again in the evening. And if you're not safe to be left overnight, then they would look for somewhere that probably that you could have a bed, and that if it's not because of a medical need, that would be in a social care setting. If somebody's not safe medically, then we'd look to get them admitted as soon as possible. So that's how we manage it. So it's obviously, both the examples I gave, the husbands didn't want other people coming in to care. They wanted to do that themselves, and that sometimes is a problem in itself, because carers need a break as well. But quite a lot of people they don't see it as them being a carer. They see it as them being a husband or a wife or a son or a daughter. So I think it's important to get the balance right, isn't it, between what you can expect of relatives and what you can provide from a service as well.
Are you happy, John?
Yes, thank you, Chase. He's my mind, no doubt many other people who, like myself, who live alone.
Lovely, thank you.
It's a very important issue.
Yes, it is. Councillor Wallace.
Oh, thank you. Let me just come back close to the desk. I can't say anything. I'm taking up on what Hazel and Catherine have been talking about, because I think we've been talking high level support for people, high specialised level to support people, which is fine. I understand that, whether or not it's in Stamford or whatever, etc. That work is going through. What does concern me is that when we start talking about the community service and we start talking about people on the lower levels who are partially discharged, don't need a bed, etc., but are still requiring rehabilitation, there isn't a great deal down there at the bottom. There isn't a great deal of support that comes out, because it's all been swept and sucked up for the people higher up, the needs. I understand that. But the people down the bottom level, if they don't get the right treatment at the right time, then they go back up the scale and going back into needing beds, because of course they haven't managed to full rehabilitate. They haven't been able to get out of that isolationism and been able to take on things both mentally and physically. The county council runs its own. In fact, I spent an hour this morning, or nearly an hour this morning, with one of the central MIS teams, which is again in Independence, which is taking up the ones off the bottom levels. But when we talk of communities, we don't see actually any community investment. You may well see another unit put in from healthcare, Nottinghamshire Healthcare, but where does the community? Where are we seeing finance going into the community end? We've got, or someone mentioned quite nice as well, Notts County football football facilities were made available, etc., as part of the rehabilitation. There's one thing that we have around the whole of the county is numerous facilities of gymnasiums and leisure centres, etc., that have got all the equipment in. What they need is finance, and so people can go in there and continue it. Because if you live in Newark, you're going to have to travel some distances, and that's going to happen anyway. So we've got a lot to tackle. I don't see that being worked on. I don't see the bottom end being looked after. The top end, yes, I understand that. I understand the needs of that one. But when you get down the further one, that is where we seem to get people seem to get lost in the system because there isn't the facilities, there isn't the time. Thank you. Can I have an answer?
Thanks, Stuart. I think Catherine's chomping at the bit for this one. You're on mute, Catherine. You're on mute, Catherine. That's it.
No, thank you. Well, no,
you wouldn't shout at me, would you?
No, but
you can do, Catherine.
In part, that's why we're here, isn't it? Because
yes.
What we're proposing to do is not to reopen Chatsworth Ward, because we can invest that money in the community service instead. And I mean, we can actually buy more with the money when you're not servicing a building as well. And we're in a really privileged position that doesn't happen very often, where commissioners have said that all the money is going to be reinvested into the community service. It isn't about saving money at all, and that's what I was trying to highlight in my examples, how we're able to improve the community offer with that added investment. I think some of what you're talking about is the part that falls outside of what health services are commissioned to deliver, all the health and well-being. And I know that a lot of the primary care now are employing people called social prescribers, and their role is to link people into those local facilities, gyms and community settings, so that we can all try and engage more in our health and well-being, and hopefully not need services to intervene.
But if we don't invest in that level, they come back up the scale very quickly, don't they?
I agree with you, and I think that's what the purpose of these social prescribers is. But that's not something that I'm involved in sorting out. But I think that's what their purpose is, because that's what people are recognising.
I'd like to see an acknowledgement that it's there, and to hear some planning going off, even at low level at the moment, to be able to take up some of these opportunities, whether or not they close Chatsworth or etc. Thank you.
Okay. Has anybody who's not spoken want to speak? No, right. I get the feeling, so this is just feeling, and obviously it's going by how I feel about all this, that I'm a lot more reassured by the plans in place to do the transition from where we are now to where we want to be. Am I getting a general acknowledgement from that? Yes. Does anybody disagree with that? No, that's good then. Okay then. So I'd just like to say then to everybody that's come along to present and answer questions, thank you very much for doing that. As you've just heard, we are a lot more assured now that the plans in place and your future plans for the service that you want to provide has given us a lot more, confidence in what will be supplied to our people that we're here to look after. So I'd like to thank you on that. I think that then eliminates the element where we said we wanted to keep Chatsworth open for an additional 6 or 12 months, so we can scratch that off the recommendation now. And I'd just like to thank everybody for the questions you've asked and the way that the questions have been answered. Yes, Martin.
Yeah, not Chatsworth, Linden Lodge.
Linden Lodge, sorry. Linden Lodge, sorry. Well brought out. Okay, so our recommendations from before, we wanted to keep open for 6 to 12 months. We would scratch that. Are you happy with that, Hazel?
Yeah, that's great, thank you. And we'll absolutely come back. I mean, I'm sure we'll be back a few more times to talk about the rehab centre as things develop.
Yeah.
But just so, just to confirm also that you're then happy for us to proceed with the Chatsworth Community Service.
Yes.
Absolutely.
Am I getting nods from everybody?
Yes,
Yes.
absolutely.
Yeah,
Chair.
yes, absolutely, Hazel.
Okay, great.
Yep.
Okay.
Okay.
Brilliant.
That all it, I think all it would say then is thanks for everybody. I think the members just want to stay on because I think we've got an additional thing is just the work programme. Are we doing that, Martin?
Yes, we can do the work programme.
Yeah, if anybody got any, just the members stay on, everybody else can go. Thank you very much. Thank you for your efforts and that. And then we've gone to the work programme.
So, Chairman, would you like me to do that for you?
Yes, please, Martin.
So the next meeting is the 26th of January. On the agenda, we'll have tomorrow's NUH, dementia in hospital. We had an item to be confirmed, which was patient transport service. That's not ready to come, so that will be deferred to a future meeting. Members might be interested here in relation to the 9th of March. We are going to have maternity services NUH on the agenda for that one.
Okay, and the only other thing I've got to say is I have asked our democratic services to look into as having additional meetings moving forward, because I think the meetings tend to go on too long. I've recognised that, even though I'm reluctant to stop people from speaking because I consider it really important issues. So we'll be able to put less on the agenda, but have more meetings, and that's being considered at the moment, and that might come through. Martin, you've indicated you want to say something.
Yes, please, Chairman. The fourth up and coming meeting on, if I can read this thing, we've got school nurses somewhere on the 9th of March. On the 9th of March. Being that was my suggestion, can I widen that topic out to healthy family teams, which includes school nurses, but also includes health visitors too? It's the same setup.
Yeah, I've got no objection to that. Anybody object to it? No, that's noted, Martin.
Thank you.
Okay, got it.
Thanks very much, everybody. You take care. Bye.
Bye.
Thank you, everyone. All the best. Bye-bye.